Thank you for the introduction and the opportunity to present today. So I'll be talking about the current status and perspective of liquid biopsies in metastatic colorectal cancer. So I wanted to start with a bit of a definition. I think most are familiar with the idea of liquid biopsies, but it's really a fairly diverse set of technologies that include both circulating tumor DNA as well as circulating tumor cells. And there's also an emerging area of research looking at exosomes, methylated DNA, and others. What we're seeing in the field of GI, and especially in colorectal cancer, has been an explosion of interest in liquid biopsies, but especially in circulating tumor DNA. And you can see the growth of the PubMed citations as one evidence of this. So I wanted to focus a bit today because a lot of the emerging data is actually in the area of circulating tumor DNA. So first of all, some terminology, and this is an area that as it's grown, the terminology has been a little muddied. So I wanted to try to clear this up a bit for you. So the first is this idea of circulating cell-free DNA, and this is the idea of any DNA that's in circulation that's not bound up by an exosome or a cell. And this includes, and is the majority of this is derived from normal cells, normal turnover of healthy tissue and other cells. In contrast, circulating tumor DNA, CTDNA, is defined to try to include just the tumor compartment. So you'll see these terms used somewhat interchangeably, but we'll try to be clear that the circulating free DNA is the entirety and the circulating tumor DNA is tumor-derived. Now, these are usually fairly small fragments, somewhere between 150 to 200 base pairs, and this is because the DNA is exposed in the environment to a lot of enzymatic degradation. But when it's wrapped around the nucleosome as part of this, then it's protected. And as a result, you end up with a large number of these fairly defined fragment lengths. There are some higher molecular weight DNA fragments that come from the necrotic cells that can also be used. And there's some other techniques to try to isolate certain molecular weight DNA moieties in circulation. But most of what you'll be seeing is taking the entirety of the DNA in the plasma. Now, there are a lot of variables, and I think it's just important to highlight this at the beginning, that actually impact the quantification of ctDNA. While tumor volume is a major component of that, there's also the concept of the copy number alterations, the tumor heterogeneity that we'll get into, the rate of release of these of the DNA from apoptosis, necrosis, or macrophage mediated, the tumor histology, the grade of the tumor, the replication rate of the tumor, data about metastatic site playing a role in this as well. Now, the DNA is enzymatically degraded, but then cleared primarily through the kidney, and so you can see renal function playing a role. Because we're looking at the tumor DNA as a small proportion of the total DNA, free DNA in circulation, anything that increases that total DNA can make it harder to detect the ctDNA, and that can be inflammation, immune response, or surgery, as one could imagine. So there's a few settings of interest for liquid biopsies. Screening, this is really tough in an asymptomatic population, but a lot of important efforts ongoing. Recurrence and detection, and then metastatic disease. So while my topic was metastatic colorectal cancer, I wanted to spend just a minute on recurrence detection. This is detection of residual disease after resection. As you heard earlier, this has been really a game changer, and I think it has the opportunity to really alter how we're looking at adjuvant therapy. So what we see is that circulating tumor DNA, when we can detect the same mutations that are present in the patient's resected primary tumor after the operation in the circulation, that has a very high specificity, meaning these patients, almost all of them, will eventually recur. It may take a year or longer, but the specificity is very high. Sensitivity is on the lower end. Some of the best studies are saying we can get sensitivity of about 50% to identify those with recurrence. And I'll come back to this in one slide in the very end. but really focus a bit on metastatic disease for the rest of the lecture. Now, I broke down the utility of CTDNA into about 5 categories, and just to touch on some of the ones that are being discussed and where there's efforts and studies ongoing. The first is really access to tumor, right? So this is the one that has been the biggest initial interest. And this is actually still in 2017 an issue of how do we get tissue from our patients. There was a series of studies, including one that we'd reported out, just showing the number of times that when we send samples off to the lab, we get a result back that says just not enough DNA or not enough quality. And there's still this kind of gap in access and knowledge. And I think John Strickler had a cohort that he's reported out that actually says patients referred in who were been previously treated with an EGFR inhibitor, and 15% of those patients didn't actually have the right molecular testing done prior to going on. So this kind of access to testing. So what do we do in those settings? Well, traditionally we'll do interventional radiology biopsy or perhaps a colonoscopy. And just to reiterate that those come with costs. So but in the US, about $8,000 average for a biopsy, and risk. And so in 2 series, including one from our institution, intrathoracic biopsy complication rate of 17%. So these do come with risks to our patients. So this is where CTDNA can come in. And I think there's been many studies that have really demonstrated the concordance of the CTDNA in tissue. I wanted to highlight one very nice one that was recently presented at ASCO, a prospective study with this goal in mind. And the bottom line is the accuracy was 93%. So if those patients that had circulating CTDNA, the accuracy was very high between tumor and plasma. Now, there was a subset that did not have detectable CTDNA, and it was interesting, the metachronous, peritoneal-only low tumor markers were all predictors of not having detectable CTDNA. Now, this brings up an issue. Okay, I've done that test as wearing the clinician's hat, and how do I interpret a RAS wild-type result? And this is probably the single most common question that I'll get. And I'd break this down into 2 different categories, an informative negative study or an uninformative negative study. And so those that are using the NGS platforms, which are the most common ones at the moment in clinical practice. An informative negative means I found something else. I found some other truncal mutations, and these were present at a high enough rate, but I didn't identify any RAS mutations. An uninformative negative is really the inverse, that either I didn't detect anything, right? There's no APC or P53 mutations, or they were right down at that limit of detection. So I thought I'd share one practical piece of information. The data suggests that if a mutation is identified, a truncal mutation is identified 5-fold above the limits of detection, but there's no RAS mutation that's been detected, along with those truncal mutations, then there's a 95% likelihood that the tumor doesn't harbor any clonal RAS mutations. Now, other utilities. Well, these are tests that actually, because the patient is right there in the clinic, that one can get the sample pretty quickly and get these results back. So the question is, how can this be used for speed of result? So in the US, certainly, one of the issues is a fractured healthcare system. So we have 70% of patients that actually get their chemotherapy administered in a different setting or location than the surgery was done. So there's a big effort to try to get paraffin blocks shipped around to the right place. And most patients don't have tissue available at the first visit. And a lot of our treatment decisions now, especially as we're moving EGFR inhibitors into first-line treatment for metastatic disease, really require this information to be available in a timely manner. So this is our data, kind of sharing where the hurdles are. It takes about 6 calendar days for us to get that paraffin block to actually show up at our institution. And then it takes another 2 weeks to actually get the molecular testing back. And then, of course, you have to sit down with the patient and actually engage upon this clinically. So you're really looking at about a month to get this information back. And this certainly varies by settings and the type of tests that one is doing, but certainly a hurdle. We had a prospective study that we did to actually ask the question about, when a patient's sitting down in front of us and we're sending off both tissue and blood at the same time, which one is coming back sooner? And the answer there was that the plasma testing came back faster than the tissue about 89% of the time. So I think certainly opportunities that would vary depending on the particular assays, but suggesting that this gives us information in a faster manner. Now, CTDNA is also faster with the dynamics of its change. So CTDNA has a half-life that's measured in just several hours at most. The studies that have looked at that have really demonstrated this is continuously released by the tumor and then rapidly degraded. And this is in contrast to protein markers, which change with half-life of days to weeks, and also have these post-treatment spikes. So what does that mean? If we have a tumor that can rapidly respond to what's going on in the tumor, what's now been shown is that these CTDNA levels can fall very rapidly, faster than we can see changes in CEA, faster than we see radiographic changes, certainly. And for example, in this reported study, that in responding patients, the CTDNA levels fall, and they fall greater than 90%. So these are not subtle changes, but most of the time are fairly dramatic and rapid changes in colorectal cancer patients. Another nice study reported out in CCR just a few months ago looked at early CTDNA response. And what this showed is looking at not a 90%, but this is an 80% threshold, that if you had greater than an 80% threshold there, you're in blue, and you can see that's associated with then the RECIST response. If you didn't have it, there was no responders that were seen, right? So a kind of a necessary but not sufficient step. And you can see big differences there in PFS. Impressively, if you didn't have a fall at that first immediate CTDNA test, your PFS was 2.4 months on whatever regimen you were on. So how do we use this, or how could we use this clinically? Well, I think certainly a lot of opportunities for clinical trial designs, but I think there are situations now where we're trying to maximize a response in a patient, for example, in patients who have potentially resectable disease in the liver, if we can convert them, where we're racing against the clock, trying to get a response to treatment while we're accumulating toxicity in the normal healthy liver, and we have to try to get try to optimize the treatment effect, or in patients with really bulky disease where an immediate response. But we also recognize that these cumulative events and toxicities, especially in later on line therapies where our response rates are low, but our toxicity rates are high, provide another opportunity where we could start to look at, could we use some of these assays to understand who should be getting a full 2 to 3 months of regorafenib or TAS-102, for example, or who may we think about alternate strategies. So what about a fourth category? So you've heard some nice data already about the idea about assessment of resistance, and we look forward to the last presentation of the session to talk about EGFR resistance. But just to reiterate that multiple mechanisms can be detected, and these can be detected a lot of times in the same patients. And I think a key point that we're starting to learn is that these resistant clones appear to be transient and actually may regress after anti-EGFR therapy. So we think about now resistance as maybe not a particularly fixed finding, but maybe something where there can be some evolution over time. And this is an area where we await additional and more robust data. But there are clinical trials. I just showed one that Dr. Villar-Sanchez from our institution is leading, where we're looking at those patients who've had EGFR, and if there are sensitive clones there, they're getting a certain treatment. For example, the ectodomain mutations, if clones have regressed, then patients can get retreated with EGFR inhibitors, and then clones that remain with RAS mutation, there's combination regimen ongoing. Dr. Schellen had nicely discussed some of the mechanisms of BRAF and EGFR resistance, but this is another area where we had findings from CTDNA that really helped inform the further clinical development. And while we were on the lookout for things like MEK1 mutation or mutations, for example, in KRAS, there were a number of mutations that would not have been on our list. For example, here's a P10 mutation that when we actually looked at it biochemically, what we could identify is that this actually activated the MAP kinase pathway. And this compilation of all the CTDNA resistance mechanisms all converged back to MAP kinase pathway reactivation. And so as you heard, this is one of the rationales that then led to the ongoing phase 3 Beacon study with the idea that the BRAF EGFR inhibition may be augmented by additional MEK inhibition. And so I think that's insights that we had from CTDNA that we wouldn't have had otherwise. So what about the heterogeneity of the tumor, right? So this idea that when we do a biopsy, we may be capturing one area of the tumor, but CTDNA does capture the entirety of the tumor burden. So we know even when we take large tumor samples and do sequencing, so these are large liver metastases from resections that kind of represent our best attempt to understand the totality of the disease, what we see is a fair bit of heterogeneity, and this is ordered by the patients, and you can see allele frequencies with a lot of subclonal components. When we look at CTDNA in these patients, you get a very similar picture, right? So this idea that the tissue and the CTDNA can reflect this intratumoral heterogeneity, and that may be then better from what we get when we're doing individual core biopsies. Now, what we did find, and this is data that with John Strickler and Ryan Corcoran been analyzing, is that the subclonality that we identify in the CTDNA is actually related to the mutational prevalence of the gene. So meaning that these truncal mutations, P53, APC, KRAS, are on one extreme, and then others such as EGFR, which are later events, and usually under the influence of EGFR inhibition, tend to be more subclonal. So these are kind of important insights that one can get. Now, with time, CTDNA now allows us to kind of monitor what the composition of the tumor clones look like. And so we see different patterns where we can have a tumor with multiple different clones, and in this graph, each color represents both a allele frequency, the amount of CTDNA, and the color represents the different clones. And what you can see are ones that progress and then respond to therapy in lockstep, or others where you can see a lot of diversity that can occur. And this is another patient of ours where there was a completely different distribution of clones present at different time points of the treatment. So when we put this together, what we can see is a really interesting insights into the tumor biology with both gains and losses of clones over time with serial monitoring. Now, what we see with anti-EGFR therapy, then looking at that, this is some data from the ASPECT study presented at ASCO this year, suggests that with anti-EGFR therapy, you actually get increased heterogeneity with time. But there is a subset that actually have decreased heterogeneity, so there is some complexity to this. And this is a graph just showing within a variety of patients the number of different alterations, mutations, or acquired amplifications that can occur in these patients. So I wanted to end then with just 2 or 3 slides on the second part of my title, which is perspectives. And I wanted to double back first to this idea of the monitoring after resection of disease. And we're used to talking about kind of the idea of biomarkers that may predict recurrence. And actually, with this data that we're seeing now on minimal residual disease, where one can say this is not a biomarker of recurrence, what we are seeing is recurrence, right? This is molecular recurrence in the tumor. And I think if we were to start to think about the post post-surgical ctDNA as a molecular marker of recurrence, I think that then opens up a new realm of being able to treat and do drug development in this space. So again, multiple studies have shown very high specificity, right? If patients have this detected in the blood and it matches that tumor, they have residual disease somewhere. And I think we need to just acknowledge this as a different group. And I'm actually proposing that we call this a stage 4 minimal residual disease, right? This is not stage 2, 3 with a high-risk biomarker. This is stage 4 disease that's just not radiographically evident. And so I think if we do that and start to think of it that way, we can really start to change our approach to these patients. So one of the things that we're doing in NRG, so the cooperative groups in the U.S., Van Morris is leading this study, is actually taking these patients that otherwise we would say shouldn't be receiving any adjuvant chemotherapy based on our best understanding to date, and in the presence of stage 4 MRD, if I had to use that terminology, then they're going on to get therapies. But I think opportunities for novel treatments in this setting as well. So final slide is, well, how do we use ctDNA in my practice? So this is what our kind of internal committees have identified and how we're using it. So if we're using it in patients where we don't have tissue readily available for testing, right, in lieu of actually doing an interventional biopsy with those caveats of what's an informative and uninformative negative test. We're using it now before and after these high-risk surgical resections to assess for minimal residual disease, so the high-risk stage 3 or stage 4 hepatectomy patients. Before and after treatment on chemotherapy, where early assessment of response could make a difference. So where we're trying to convert patients, for example, we need to identify the optimal regimen. And then when we're looking for targets in patients that have been heavily treated, especially when they've treated and responded to certain targeted therapies in the past where the tumor has demonstrated evidence of evolution in prior studies. So I'll end just with some acknowledgments for the work there. I think I highlighted a lot of the colleagues along the way that had been providing some of the data presented. So thank you for your time.